Hello again, thank you for tuning with us. My name is Josh Jacob, this is my colleague Ash Srinathan. Today we're going to talk about total hip replacements. Now tell me Ash, who gets a total hip replacement?
So, total hip replacement, we give total hip replacement in various subsectors of population. Most of them are osteoarthritic patients. Simply that means there is wear and tear, the cartilage has gone and the bone is rubbing on the bone, and that is what causing the pain. The second group of patients are patients who need a hip replacement secondary to a fracture. The third group of patients are patients who might have rheumatoid arthritis or generalized other varieties of arthritis, which has also caused to have the cartilage worn out. Now these are the three main subgroups. There are many other groups of patients which we give arthritis, but mainly these are the groups of patients which we give hip replacement on.
Would it be fair to say that the fracture population of patients is slightly different to the other cohort that you mentioned?
Absolutely, yeah. The fracture group is very different to the osteoarthritis group, and the recovery period is also very different in compared to both subgroups. So I always tell the patients that if you have broken your hip, the recovery from a hip replacement is much different than if you're recovering from an osteoarthritic leading on to hip replacement.
Right, okay. So what generally is involved in a hip replacement?
Good question. So the hip replacement, the hip as a joint is a ball and socket joint. So if I may show
you. Is that one you made yesterday?
Yeah. Oops. So that is a ball. So that's a socket. Sorry, that's a socket. That's a ball, and that is what a hip joint is. And a hip replacement is replacing both parts of it, so the bone is not rubbing on bone and you don't have any pain. Now, Mr. Jacob, do you want to show your metalworks which you normally use for a hip replacement? So what are the implants you normally use for hip replacement?
So generally speaking, the average population that comes through our doors gets a total hip replacement that involves replacing the socket with something like this, similar to this, and replacing the stem with something like this. And the main articulating interface is made of either a ball, which is metallic, or ceramic, depending on the flavor of the day. Not exactly. And also a polyethylene liner, which is pretty much a constant feature in most hip replacements. Now you may have heard of cemented and uncemented hip replacements. I generally tend to use uncemented hip replacement, and those who have pretty good bone stock without any overt comorbidities, and those who are slightly on the elderly population side will get a cemented hip replacement.
The bottom line is we use cemented or uncemented based on the bone stock, but it really would not make any difference to the patients, whether it is cemented or uncemented, and the results of both are very similar.
Yes.
Yeah, do you agree with that?
Absolutely.
Yeah.
Now you've just, as a patient, you've come and seen us. What does the patient need to do, say just before going in for a hip replacement? They've been put on the waiting list, and is there anything you can counsel them? What do you tell them normally?
Sure. So before, Mr. Jacob, before going on the waiting list, I would strongly counsel the patient regarding the hip replacement, and what you should be asking about to your consultant or your GP about a hip replacement are: how badly is this affecting me? Is it so bad that I can't sleep at night? Do I regularly require painkillers to do my daily activities of life? And if so, have I tried all other means of decreasing or alleviating my pain? Then only you should think of a hip replacement. A hip replacement, as Mr. Jacob said, is a fantastic surgery, but that is not the first one you should turn to if you have arthritis. Do you agree?
Absolutely, yes.
Fine. And coming back to your point of a pre-rehabilitation, so it is extremely important that one keeps oneself very active, because the point is we are only replacing bone. We are not replacing muscles. So you need to keep yourself active, you need to keep yourself supple. Swimming, spinning, anything you can do to keep your muscles working is very good. Try to lose as much weight as possible, which will help you which will help the recovery of the surgery. Just before, and it is quite important to look at lots of patient videos, talk to patients, so that other patients who have it done. So one is mentally prepared for the surgery. And just before surgery, it is very important that if you don't have any cuts, no bruises in your legs, if you have pets, make sure the pets are not scratching your legs, because it's very important to look after the skin before surgery. Have you had problems on the day when patients come in with bruises and cuts in their skin?
Yeah, well, ever so often, maybe once or twice in every 6 months, you're just surprised by an unprecedented event where someone's knocked their leg or scratched their leg inadvertently and cause problems, which means that we might have to cancel so that we don't predispose to any undue exposure to infection. So once you've seen a consultant on the day of your clinical consultation, your name gets emblazoned in the register so that you will be on the waiting list. You'll be called for a full MOT. The MOT gives you a free service, checks your blood, checks your urine test, your heart, your lungs, your ECG, all the blood tests. And once they make sure that you're up to scratch and you're ready for a hip replacement, we're doing that simply to minimize complications and to pick up any surprises that we don't want to expect on the day of procedure. Now, is there anything that you advise your patients, Mr. Nathan, like things like smoking, and you did mention about weight loss? They do go a long way, I take it, for the success of the procedure.
Thanks for reminding me. Yes, smoking. If you are a smoker, always the advice is to decrease your smoking or quit smoking, because smoking affects your healing process. If you are excessive drinker, it is quite important to come back to the guidelines of the normal units which you can have. These are very important for you to have a generally good health, good diet, good mental approach to the situation. I always tell the patient that you are going to run the 100 meters. So before you run the 100 meters, you need to optimize yourself as well as you can. So from the day of the surgery, your recovery becomes as quick as possible.
Very good. I also tell my patients not to shave the operated site just before the procedure, just because shaving can increase the colonization of bugs around the operated site and then can predispose to infection. We often advise taking a chlorhexidine bath.
Yes.
Just to, again, bathe your body in antiseptic solution, and that way be prepared. But apart from the fact that we also optimize our patients before the procedure, you as a patient need to make plans of how you can help yourself after the procedure, because we can't come home and stay with you, nor can we send people to stay with you at home. So it's best to inform family members, rally around you for the first 2 weeks, ensure that everything is pucker and you're least indisposed to problems and you foresee complications. So if your bedroom's upstairs, we'd advise you to climb the set of stairs. There's no harm, because the physiotherapist will make sure that you are competent to climb stairs. But if you have to bring the bedroom down and raise the toilet seat, bed down, I beg your pardon, yes, don't try and bring the bedroom. That's the last thing we want to do.
You don't want a builder coming to your house to get your bedroom down, to get your bedroom down. Yeah.
And things like raising the toilet seat and using an extendable grabber so that you can put your own socks, slip-on shoes, all the other things that you will be told before the surgery. Now, you've come to the day of operation, you've seen the anaesthetist, you're going to go under the knife. And on that day, it's Mr. Unithan as the surgeon. Now tell me, what sort of approach do you do for a hip replacement? So, and how big is your incision?
So it's a very good question, because there are various forms of approaches. You can go from the front, you can go from the side, you can go from the back. And if you look at literature, there are various reasons where has been described why one should do that. And there are advantages of certain procedures, there are disadvantages of certain incisions. But I always tell my patients that whatever approach your surgeon is comfortable doing is what the approach should be done. Because the bottom line of an approach is that the surgeon is able to correctly see where the implants have to go. So the answer to the question is, how big is the incision? And my answer is very simple. My incision has to be good enough for me to see where I am putting the implants, because this will last you for 20 odd years, and and hence it's quite important that the implantation is correct and the surgeon is able to see all the relevant anatomical structures that needs to be seen. That also does not mean that you will get a sharp bite, but it is answer to the question is, it is what the surgeon is comfortable with.
Yes, absolutely. So we make incisions as big as they need to be, but as small as possible. At the end of the day, it has to be safe and it has to be effective so that the hip lasts and tries and outlives you basically, and you get the best mileage and performance out of the hip.
And the point is, you have to put something as big as this and as big as this. So if you have to put something which is of your life anatomical size, it needs to be at least an incision to get these things in the correct position.